consent. Usually I'm a consultant physician. Is it all right to examine you? Yeah. Before any system examination, first we have to do the general examination. Then you have to come to the foot end of the patient. The first thing is you have to see whether patient is comfortable or not. Okay, then the patient is whether tachypneic or not, and whether the patient is having shortness of breath, and whether patient is having peripheral edemas like ankle edema, whether patient is having any cannula, whether patient is getting oxygen, whether patient is in distress or not. The steps in the cardiovascular system examination is the direction of the venous blood flow. That is pulse, blood pressure, jugulus venous pressure, and the precordial. General examination also start with the hand. What are the physical signs you are going to elicit in the hand? First thing, you have to look for whether patient is having a bluish discoloration of the fingers. That we call cyanosis. Cyanosis we divide into peripheral cyanosis and the central cyanosis. When there is a bluish discoloration of the fingers, we call it a peripheral cyanosis. When there is a bluish discoloration in the tongue and the mucous membrane, we call it as a central cyanosis. You have to look for clubbing. What's a clubbing? The loss of curvature of this nail bed. What are the causes? Cardiovascular causes causing the finger clubbing? There are only two. First thing is an infective endocarditis. The second thing is a cyanotic congenital heart disease. And then you have to look for the elongated the streak-like things underneath the nail. We call it splinter hemorrhage, and sometimes you can see the Janeway lesions and the ossular nodes. Those are peripheral stigmata of the infective endocarditis. Right? Endocarditis. So if it is there, you have to detect it. Right? So that is, and at the same time you can compare with your palm and you can see whether patient is pale or not. And you start with the pulse. Now we are going to examine the cardiovascular proper. So first thing is a palpation of radial pulse. How are you going to feel the radial pulse? Right? So you take all these fingers and keep over the radial pulse, and you can feel. Basically we use our middle three fingers. Right? So then the pulse, what are the things you have to look for? Rate, rhythm, volume. Right? Rate, rhythm, volume, and then the character of the pulse. Usually we check for the character of the carotid pulse, and whether there is any delay, called as a radio delay, and the collapsing pulse. Right? How are you going to keep the pulse rate? You keep over the radial pulse and you count for a 30 seconds. Right? 30 seconds and multiply by 2. So normal pulse rate is 70, but 70 to 100 it always as a normal. Right? Then that is a rate, and then the rhythm. What is the pulse rhythm? So you are expecting another beat one after the other. That is our then we call as a regular rhythm. Right? When the pulse beat is not coming as we expected, then the irregular pulse. Right? So irregular pulse we divide into two. Regularly irregular. Regularly irregular means so there is the pulse is not regular. Right? So pulse is abnormal, but abnormality you will detect in regular basis. Regularly irregular pulse. Yeah, what's the example? Ventricular ectopy. Right? Ventricular ectopy. And then there is a pulse rhythm would be the irregularly irregular pulse. Right? That is only one example in under the sun. That is atrial fibrillation. So volume of the pulse, you can detect it very obviously. We call it as a good pulse volume. Sometimes the pulse is a very weak or feeble. We call it as a thready pulse. Thready pulse. Then we can say the low volume pulse. Right? The next one is a character of the pulse. Pulse before come to the radial pulse, we have to check another type of the character pulse. Character of the pulse, that is collapsing pulse. How are you going to check the collapsing pulse? You have to lift the patient's arm up. Before lifting arm up, we have to make sure that the patient does not have any problem in the shoulder. Patient, do you have any problem in the shoulder? No. Right. also. So how are you going to check the collapsing pulse? You have to hold the hand like this, and you feel the radial pulse with the palm of your thumb, palm of your hand. Right now you can feel the pulse. Right now, what you have to release your hand as long as you can't feel the pulse. Now I can't feel the pulse because I release. Right now, lift the hand up by applying the force from this hand. Right, like this. And when as we are lifting the arm up, we have to make sure that the no shoulder pain. Right? So this is, if you can feel the pulse again, that is collapsing pulse. If you do like this, that's a wrong technique. Right? Wrong technique. What's happened? So we have not eliminated the gravity. Due to gravitational effect, you can feel the pulse again. So the other technique is that you can hold the hand here. Right? Hold the hand here. And as I did in the first maneuver, keep the pulse, feel the pulse, release your hand as long as you can't feel it, and lift the hand from the elbow as long as if you can feel it, then we call it as a collapsing pulse. What are the causes for the collapsing pulse? Any hyperdynamic circulation, fever, pregnancy, thyrotoxicosis, right? There is an underlying cardiac abnormality which has a characteristic feature is a collapsing pulse, aortic regurgitation. Now the blood pressure is the next thing. So we have taught you how to check the blood pressure. Right? So then we come to the third step, that is a jugular venous pressure. So first you have to feel the carotid pulse. Right? So carotid pulse, usually you have to use your thumb. Right? Thumb and press over the carotid artery and the anterior part of the sternocleidomastoid and the larynx, and then you can feel the carotid pulse. Right? And then you can get the character and the real volume of the carotid pulse, but make sure that you should not palpate carotid pulse simultaneously, both sides. Right? So if you look the jugular venous pressure, patient should be kept in this position, 45 degree, and it should be well lit, right? Or you can flash a torch, and so you can see the usually the venous pulsation. You can see the internal jugular pulsation. You can see here, and the upper wave. It is a waveform, and what you have to do, you have to take the upper margin of the wave and take the ruler, and this is the sternum, right? Sternal angle, and keep another ruler here. Then the vertical height from the sternal angle is we call as jugular venous pressure. Then we come to the precordium. Precordium means that all we call as the anterior part of the chest. So what are the four principles in the precordial examination? Again, inspection, palpation, percussion and auscultation. What are the things you look for in the precordial examination? Again, you have to look for the scars. Where are the scars? You can see the midline scar. Right? This is this bone we call as a sternum. Right? There's the mid of the sternum we call as a mid-sternotomy scar. And where are the other scars you can see? The lateral scars. You can see sometime when the patient is having a mitral valvotomy or past history of mitral valve surgery. Usually the cardiothoracic surgeon open the thorax from this angle. So any scars, right? Sometimes you can see the scars from the either side. You can see the scars, right? Okay, and then the scars is the first thing, and then any deformity of the chest. What are the deformities? Sometimes you can see the sternum is depressed, right? And then sometimes sternum is like a pigeon shape, the prominent shape. That is called pectus excavatum and pectus carinatum, right? So the any abnormality. Sometimes you can see the any abnormal chest, right? And then what are the other things? You can see the visible pulsation of the chest, right? Sometimes apex or these other areas, you can see the visible pulsation. Right? How are you going to palpate the precordium? You have to use your dominant hand, the right hand, right? So you start with the palpation of the apex of the heart. This is the apex. Right? What is the apex? How are you going to define the apex of the heart? Is the outermost and the lowermost palpable area. Usually apex beat is you have to feel your finger over the apex here, right? Usually apex beat is middle to the this. What is this line? Mid clavicular line. Mid clavicular line, and it is in the 5th intercostal space. You have to count. So this clavicle is at the 2nd intercostal space. You have to count 3, 4. The nipple value is the nipple level is at the 4th intercostal space. This is the 5th intercostal. If you can feel the apex, there are 2 types of apex you can feel. What is the 2 type of apex? First thing is a thrusting apex. The other one is a heaving apex. After keeping your finger, right? So if your finger is moving like this with the pulsation of heart, so we call as a heaving apex, right? Heaving apex. And sometimes if you can keep fingers over the apex, you can feel something come and hit over your fingers. That is thrusting apex, right? Heaving apex and thrusting apex. The heaving apex you will get in the condition where the muscle mass is thicker, like a aortic stenosis, right? The thrusting apex where you get a volume overload, like aortic regurgitation and the mitral regurgitation. So there is another type of the apex, the tapping apex. Tapping, you know that it's come and hit fast. Where do you get a tapping apex? When there is a mitral stenosis, and at the same time you feel, sometimes you can feel the palpable murmurs. That is we call a trill. Murmur grading, there are 1 to 6 grading. The murmurs grade is more than 3. The 4, 5, 6 murmur, you can have a feel the palpable murmur we call as a trill. If you detect a trill, you have to say that okay, this patient is having a trill in the apex area, right? Okay, trill. Then we move towards the medial. Then we are going to palpate the epigastrium. So you feel your hand over the epigastrium, this epigastric area. See whether you can feel any pulsation. When there is a right ventricular enlargement, you can feel the cardiac pulsation in the epigastrium. Right. Then you move to the parasternum. This is a sternum, right? Then this area called the parasternum. So then you keep, there are 2 types, 2 ways you can look for the parasternal heave. Heave means then you can feel something come and hit on your palm, right? So use your ulnar border. This is the ulnar border of your palm. So you keep the ulnar border over the sternum, and you can see if there is a right ventricular enlargement. You can see something come and hit on your ulnar border of the hand. We call a parasternal heave, this way, right? So you can recheck the parasternal heave, space your fingers out and keep your finger in between the intercostal space and recheck parasternal heave, right? Check parasternal heave and recheck parasternal heave. Then you come to this area. So this area called, which area? Pulmonary area. So what are the areas in the precordial? This is mitral area. This is tricuspid area, this is pulmonary area, this is aortic area, right? So the way of the examination, starting from mitral to go to tricuspid, go to pulmonary and come to aortic area, right? So then you come to the pulmonary area, keep your finger over the pulmonary area, see whether there are palpable murmurs or trill, and then come to the aortic area, feel aortic area, then go to the carotid area and feel whether you can feel any bruit, any pulsation, right? And feel the other side. So that is palpation, right? Palpation. You come to the percussion. Usually cardiac auscultation, the percussion, we are not doing the cardiac percussion. Now we come to the last bit of the cardiovascular system examination. There you need your stethoscope, right? Stethoscope, you know that this space is called a headpiece, right? These are ear tips, right? And this space is you have 2 parts. This bit is called diaphragm, this part is called bell, right? So you can turn your stethoscope this way and this way. The diaphragm we use for the high pitch murmur and the bell we use for the low pitch murmur, right? So they have to apply the correct way. You know that the stethoscope is keeping like this, right? So our ear canal is anatomically situated anteromedially. So this is the correct way of putting your stethoscope, right? Not this way. If you put this way, it is not firmly touch the ear canal, and this all these sensation are depending on your how much this ear tips will touch the ear canal and how comfortable, how tight, right? Whether if the sound is conducted through this tube. So then one of the most important things is two earpieces, right? So you keep this thing, right? And then you lift it up until the 90 degree. Then the touch is more and more. Then the contamination, the touching with the ear tips, with the ear canal is more. And then you start with your mitral area, right? This is the mitral area. To keep there your stethoscope and holding the headpiece to the 90 degree to the ear canal and listen. You can see the first heart sound and second heart sound. Love, love, right? Then concentrate to the first and second heart sound. If you get any additional things like murmurs, you have to detect. Right? So you start with the mitral area, and if you can see the pan-systolic murmur in the mitral area, usually it's a mitral regurgitation or mitral incompetence. Right? So mitral regurgitation murmurs, usually it is radiate to the axilla. At the same time, you have to auscultate the axilla. You can say the same intensity as in the apex as well as in the axilla. Then for the soft murmurs, right? Usually we have to use the bell. What is a soft murmur you can hear in the mitral area? That is mitral stenosis murmur. It is a mid-diastolic murmur. Right? You have to keep your bell over the mitral area and ask the patient to turn to the left side to get the more intensity of the bell. Turn to the other side patient. Right? Thank you. Right? Keep over there and listen to the whether there are any diastolic murmur like a mitral stenosis. Right? Okay. Now using this diaphragm of the bell. Now you use your stethoscope by 1 inch at a time. That is called inching technique. So you start with the mitral area and move 1 inch up to the tricuspid area and then go up and then come to the pulmonary area. Right? There you can see the more prominent is the second heart sound, and then come to the aortic area, and lastly you have to come to the carotid area. There you can hear a nice ejection systolic murmur when there is a severe stenosis, aortic stenosis in the aortic area. Right? And at the same time, can you take a deep breath and exhale and hold your breath for a second and bending leaning forward. Thank you. Now take it. That is a maneuver. You detect the early diastolic murmur in aortic regurgitation, right, of the precordia. But you have to make sure that the lung bases, right? Lung bases also. Can you please take a deep breath in and out for the patient? You have to listen lung bases bilaterally to look for crepitations. Right? What are crepitations? Right? Crepitation is a sound. If you take the hair and rubbing like this, you can hear a sound that is called crepitation, right? If he has the good shampoo, right? And then and he's a nice hair, then this sound is a very fine, right? That's called a fine crepitation. Coarse crepitations, where you get in some respiratory conditions, right? Respiratory condition like a bronchiectasis and the pneumonia, right? So you auscultate both the lung bases from back or from posterior and see whether patient is having bilateral fine inspiratory crepitation. If it is there, you can say that this patient is in heart failure. And at the same time, you take a chance and press over the sacral area. Press over the sacral area, see whether there is any pitting edema. If it is a sacral edema, that indicates the patient is having which heart failure? Right heart failure. The last thing for the cardiovascular system examination, you have to feel the liver also. So the liver is situated in the right hypochondria, right? So what you have to do is you start from here, right, and ask to take a patient deep breath in, and you move your finger. So take a deep breath in and out, Yoshi. Right. So you move in and out, right? Go gradually up, and then you can feel something come and hit on your tip of the fingers. That is liver, right? If it is a liver, then you take, this is the costal margin, and you measure from the distance from here. So if it is the liver is enlarged, you have to mention, we call as a hepatomegaly. And in the hepatomegaly or the liver enlargement, you have to check whether this patient is having the tenderness, right? So if the patient is having the tender hepatomegaly, that indicates the patient is having a tricuspid regurgitation, right? Tricuspid regurgitation, or the patient can have or in the heart failure with a congestive hepatopathy. When this is a venous congestion, the liver become enlarged and it is tender, right? Other things, the liver palpation is important if you are not sure, right? So whether your jugular venous pressure, whether this is the venous pulsation or the carotid pulsation. The one maneuver you have to check is you press over the liver and see whether what is happening to the upper margin, the top level of the jugular vein, right? So we call as, when it is pressed the liver, the JVP will goes up. That is called hepatojugular reflux. Then the other thing is the spleen. So this come under the abdominal examination, but certain condition. What are the splenic enlargement with regards to the enlarged spleen with regards to cardiovascular system examination? That is again infective endocarditis. When the spleen is enlarged, the direct is moved medially and inferiorly. Right? So you have to start from here, right, and move from here, and ask the patient to take deep breathing. Right? So take deep breathing and out. Right. Okay. So spleen is difficult to palpate. It depends on the size of the spleen. If it is the huge spleen, the large spleen, you can see even the lower border is here, anterior not. So if you can come here, still you couldn't feel the spleen, ask the patient to turn to your side and ask to take deep breath in and out. So still yes, so his spleen is not palpable. If it is there, you have said this patient is having enlarged spleen, right? Enlarged spleen, and so that is two abdominal organs which are related to the cardiovascular system examination. And then the last thing, so you have to feel whether the patient is having ankle edema. How are you going to elicit the ankle edema? This is your which malleolus? Medial malleolus, right? Medial malleolus, bony prominence, right? Bony prominence, and here also is a bony prominence. And so you have to feel, right? So feel, keep your thumb, right, over the few seconds over the bony prominence and lift it up. If it is an ankle edema, if there is an edema, then you can see a dimple, that is called a pitting edema. right? Pitting edema. And if the sacral edema is there, pitting edema is there, the patient jugular venous pressure is elevated, which type of heart failure? Right heart failure, right? If no ankle edema, no sacral edema, no jugular venous pressure, only the bilateral ankle edema, bibasal fine inspiratory crackles, right? With the third heart sound, which heart failure? Left ventricular heart failure. If somebody is having both physical signs, right side and the left side, we call as a biventricular failure or congestive heart failure. Usually the peripheral pulses are supposed to examine. Right, out of these peripheral pulses, we check whether patient is having a bilateral, whether you can see the bilateral radial pulses at the same time. Sometimes when there is a patient with a young hypertension, right, when the upper torso is well developed than the lower torso, we are suspecting the one condition. What is that? Coarctation of the aorta. Coarctation of the aorta. They have an upper torso. Upper half of the body is well developed than the lower half. So we do a radio delay. Right. So we check for the radio delay, and then you have to feel the femoral pulse also. Right, with the consent of the patient and the femoral pulse, and then if there is a delay, so you can feel the radial pulse, and the femoral pulse is lagging behind, we call as a radiofemoral delay. If the patient is having some peripheral vascular disease, you can see both the popliteal pulse and the dorsalis pedis pulse here, and anterior tibial pulse here. Thank you very much, Oshan.